Please welcome Seema Verma to the stage.
Well, good morning, everybody. I hope everybody had a good day yesterday. Appreciate seeing so many energized faces, and I hope everybody had a chance to see a lot of the new technology. I thought yesterday's conversation was great. We had a lot of discussion with the provider side. We heard from life sciences. But today I'm excited to have Dr. Patrick Conway with us today. Patrick is the CEO of Optum and also an old friend and colleague from my days at CMS. So welcome, Patrick. Great to see you.
Great to be here.
All right, so Patrick, I first met you when I came to CMS, right? Third floor of the Humphreys building.
Yep.
Known for the little rats that run around.
Yep.
Yeah, it was great. I think you warned me about that, if I recall, right? Be careful.
They're still there.
Yes. They're getting bigger, from what I understand. So. But Patrick, always really appreciated your background. And so maybe for the audience, just go back to your roots, where you started. You've had an incredible career journey and done a lot of different things. So maybe let's start with that.
Yeah, so first, just thanks for having me. For everybody, did get to work with Seema at CMS and just was a joy, learned a lot from you, and just terrific.
I think it was the other way around. I learned from him, so.
And public service matters, so for everybody who's doing it now and those of us who have done it in the past, thank you for your service, honestly. Look, my background, grew up in Texas, did consulting for a little bit, trained as a physician. I'm still a practicing physician. I take care of kids on weekends, not this weekend, but the next weekend. I will be, usually with multiple chronic conditions, often on Medicaid or uninsured in the Boston area where I live. Was in government twice, so the first time in the Bush administration, second time Obama to Trump. Was never political. The second time around, chief medical officer, ran the CMS Innovation Center, deputy administrator and acting administrator before you. And then was CEO of Blue Cross North Carolina, so ran a health plan, tried to drive change at a state level, improving health outcomes, affordability, integration of care, and really driving the outcomes you'd want at a state level. And then I've been at Optum 6 years. In classic Optum fashion, I've had 4 different CEO roles in 6 years, and CEO of Optum now for the last 5 months. And just a great opportunity to drive change in the health system. I've tried to do it in the public and private sector. Also was in health systems a couple times, so a lot of different jobs. But the same theme has been, how do we make the health system better for everyone?
Yeah, so you've seen it really from different vantage points, right? So you saw it at CMS, and you were at CMS for what, 10 years?
Almost
18?
7 years, yeah, so, and then 3 years first, almost 10 years of government service, yeah.
Right, so that's huge from driving change inside the government, understanding the large, big policy issues. You're a doctor on the front line, so you understand the patient perspective, the provider perspective, and then going to payers, not-for-profit and for-profit, and in consulting. So that's a really very, all of that perspective.
What I tell young people, though, is I did not plan out my career at all. And I'm gonna keep with that strategy. I've got some criteria, but no plan.
Yeah, it's so with all of that, right? All these different roles, different perspectives. Kind of, what are your, just your overall thoughts about? I mean, look, there's so many different directions we could go in, but just kind of your overall thoughts. A lot of times I talk to people and the system is broken, and that's just kind of the overarching theme. But from all of your different sides, you kind of have an understanding from each perspective.
Yeah, look, the system does need to perform better. Mm-hmm. So, I put it in, we've talked about this, you've got healthcare outcomes and quality where there's just too much variability. You have amazing care, but then you can have too many people falling through the cracks of the system. You've got a set of transparency and how do you engage the consumer, how do you engage the patient, what does that look like? And I know we've both done a lot of work on that and how you make that better. And I think we've got a huge opportunity there, and I'm sure we'll talk about this in the age of AI and technology. How does that look different? And then if you look at the overall system, and we do a lot of work on this, how do you enable a system that performs well, both on quality but also on cost? I was just with a bunch of employers yesterday and brokers for the insurance industry. And I can tell you it's very clear. The affordability is always an underlying tension, but we are in an era right now of medical trends higher in Medicare and commercial and in Medicaid than we've seen in a very long time. And they are desperate for solutions to help manage the cost of their benefits and the out-of-pocket costs for their employees. Medicare Advantage has a lot of challenges right now, largely driven by the trend, the medical trends. So how do we drive the affordability in the system that we need? I worked in the drug space. If you look at the costs of drugs in the US versus other countries, 5 to 10x the cost list prices. There's some policy solutions there, but also how do we across the system to try to get access to drugs, but that are affordable for people? Because if they can't afford the drugs, it's obviously not going to have an impact.
Right. And you were also CEO of Optum
RX for a couple of years.
Yeah. So I want drug pricing. We could spend the whole hour on that one, but that perspective, right? So you talked about trend, which I think is a very current issue, and I know I've been asking a lot of people, what do we think is driving some of that trend?
Yeah. So I think there's a few things. So if you look. Make a couple comparisons. If you look about the U.S. versus other countries, the largest cost disparity is in hospital and health systems and drugs. We just talked a little about drugs. Hospital health systems right now, we are seeing significant uptake in trend as well. Interestingly, it's not utilization as much as it is price. So admissions per thousand, et cetera, in our system are actually not going up substantially. But when you look at the intensity and the payment of the services, that is going up. So think increased specialist visits, think more inpatient versus observation stays. I think the macro question we need to ask, and I actually talked about this yesterday too, and we were talking about a little bit earlier, the clinical care, to be clear, is the same. I work in the hospital. If a person, a child or an adult, is in the hospital for a day and you care for them, that care is similar. But you're seeing the charge for care to be substantially more. And if you think about observation versus inpatient, it could be a $2,000 price tag versus a $25,000 price tag. So there's a lot of incentives in the system to move to that higher price tag. If it's clinically warranted and you can prove that with the data, great, we should pay appropriately. If it's not clinically warranted and people are using tools to just get a higher payment through the system, well, that's waste, and that's the kind of care that we should all care about, appropriate payment for the care delivered.
Right, and that's a great point, right? Because we're seeing that I think premiums are going to go up this fall, right? One of the highest rate increases in 10 years across the board, right? So there is, and so employers are going to push back, individuals are going to feel that. And I think it's sometimes with payers and providers, lots of friction. But kind of give your side of how does the payer look at these issues? Because at the end of the day, when people moan and groan, they're going to be angry at the insurance company around the premium. I think we can appreciate that providers on the front lines, they're dealing with staffing issues, they're dealing with workforce challenges. So, both sides of it, right? You can appreciate that side running Optum, right? And I think we should have talked about this, but like kind of describing your job, right? There's Optum RX, but there's Optum you guys are delivering health. So answer that question and then come back and tell me, how do you look at it from the payer and provider viewpoint?
Yeah, so great question. Let me start by describing UnitedHealth Group and Optum, just to level set folks. So you got UnitedHealth Group. It has UnitedHealth Care, large insurance arm with Medicare, Medicaid, commercial. Then you have Optum, which has Optum Health. That's our care delivery arm. So that's doctors, nurses, practitioners in clinics, in the home, mental and behavioral. So we've got almost 4,000 now, therapists, psychiatrists, others, home health nurses, hospice. So think ambulatory surgical centers, think a very large national care delivery system, all centered, on effective care delivery, value-based care. Then you have Optum RX, which I led for a couple of years, pharmacy care services, so a pharmacy benefit manager that's managing the drug spend for employers, payers, unions, others, and pharmacy services, think specialty medicines delivered into people's home infusion, community pharmacies for mental and behavioral health. Optum does so many things, sometimes you don't even know. There's these amazing things called Genoa that are integrated mental and behavioral health care, often with federally qualified health centers or community mental health centers. and they're provided integrated care for people with substance use or schizophrenia. Great evidence, adherence better, outcomes better, cost lower. And then the last part of Optum is Optum Insight. That's our data technology business. We have ways we're partnering today with Oracle and hopefully more in the future. And there we're supporting 9 out of 10 payers in the country, approximately almost 9 out of 10 hospitals and health systems in some way on things like prior authorization and payment integrity, revenue cycle management, the underlying system to make care effective. It's okay, I know this is a long answer, but I want to hit your second one too, with a couple sort of patient examples, if you will. So in the Optum Rx space, we did work, two products I'll tell you about. One was called, it was a specialty savings program where we searched using big data all the ways patients could get support, including from pharmaceutical companies, for lower copays. So for specialty medicine, think cancer, severe neurologic conditions. The median copay went from substantial, think about $100 to $5 median copay. Wow. The out-of-pocket costs for cancer went down 88%. We saved $1.3 billion in 1 year for consumers through this technology solution. I got an email from a lower income farmer who said, I'd actually been going on and off my cancer medicine, and now that it's $5 copay, and I wasn't telling my wife, by the way, because I didn't want her to know. But now with this solution, I'm taking my cancer medicine, I'm doing better, I'm able to work again. That's why you do the work. Like the big stats are important, but that's somebody's life, major impact on. We did work in prior auth, and we were talking about this earlier. Prior auth, a lot of these we need better terminology, right? So it's actually getting the right medicine to the right patient at the right time affordably. But we took the current system and said, if you automate that, and it usually takes 8 hours on average, but it could be days or weeks. If you automate that, how quickly could you approve drugs, all the way through the workflow? We got to meet less than 30 seconds.
Wow.
Faster for the patient, faster for the doctor prescribing, better, right medicine, right patient, right time, affordably. So when we work together across the system, those are the kind of solutions we can put in place.
So that's an interesting point, right? Because if we look at these premiums that are going up, you guys are trying to manage care. You want your patients to be good and be okay and have access to medications and not let affordability impact their care. That's your goal, your mission. But then the opportunities, right? So if we think about where you are today, how are you trying to manage it? What are you sort of seeing, like in terms of your role at Optum, all the challenges that you're facing, where do you see the biggest opportunities to drive forward what you're trying to do at a mission level, given the challenges that you have? Yeah,
I'll call out 3 areas, and I'll try to give an example in each, because I think it'll be helpful. So in value-based care, we've worked on this in different ways, and different bipartisan support. We need to maintain that bipartisan support. When you pay for better outcomes at a lower cost, it is the future of the U.S. health system. I don't think we're going fast enough. I think we need to scale faster. I bet you agree, but that's a ton of our work. And we take full risk for about 5 million patients and significant two-sided risk for 7 million. That is one of the, if not the largest, value-based care system in the country. And then results, we've got published data on this. Hospitalization rates go down, so think double-digit plus. Avoidable ER visits go down, think double-digit plus. Quality and outcomes and experience improve, and this is a peer-reviewed literature we've published. So it can be successful, it is successful, proven data, and now we're scaling that across the country. I'll do another story. I go see a woman in South Boston that is dual eligible, low income, late 80s, lives alone because widowed, used to be hospitalized 10 plus times a year. She's got literally 12 chronic conditions. I went in with Dr. Debbie, who the woman hugs, and this woman now, through a comprehensive care, physical, mental, pharmacy, social, no hospitalizations, blood pressure, diabetes, et cetera, under control. When she has a problem, she knows she calls Dr. Debbie's care team to get help 24/7. When she needed support for food and transportation, we connect her, we provide it either directly or through a partner. When her husband passed away and she needed mental health support, she needed a brief period of therapy and mental health support. We provided that. I mean, that's what we'd want for our own mothers or loved ones. I mean, that is a comprehensive care program. So that's value-based care. I'll try to be a little shorter. Consumer, we're using AI, digital, et cetera. 26 million calls was the last stat I saw. We're using AI agents to help the customer service rep make the calls faster. We also think we do about 300 million calls in UnitedHealth Group every year. We think we could take out 50% or more of those calls over the next 12 to 24 months, led by Sandeep and others in our team, because you enable digital interactions and you have the right information on your phone, whatever your healthcare need is. Could partner in those areas as well. And then the last area we talk is system enablement, which is really some of the examples we've given on, how do we make the system and the friction, to use the go down? How do you get away from this where we've got thousands of people in the provider's back office and the payer's back office literally fighting via fax and other methods about what's covered and what's not. So real product we're deploying right now, it's real-time benefit check. It's literally just confirming in real time with technology, is this covered? Therefore, what is the payment? You connect that to Optum Financial, and we can even support consumers with that payment. So how do we enable the system to be simpler, easier, more effective?
So what I appreciate with what you said, and we can talk about value-based care. We'll come back to that because you and I worked on that for a long time.
We did.
Was it New Year's
ACOs on Christmas Eve?
Yeah.
If I remember
It was New Year's Eve.
Or New Year's Eve.
No,
I don't know, some holiday.
Christmas Eve or New Year's Eve, but we worked that out over a couple of hours and got the policy worked out. But, we were driving that. That was 2017 that we were trying to push that forward. Yeah. In your mind, what has kept value-based care back from really scaling in the way that we had envisioned, right? And also now being in government and then now, coming over to this side, private side, how are you looking at value-based care now? Why hasn't it scaled at the rate that we thought it would or we wanted it to?
Look, it's a great question. I take a step back. I don't know if we ever talked about this. So when I worked for Secretary Leavitt in the mid-2000s, in value-based care, and I'll give him credit for this, he said, I think this will be about a 40-year journey.
Wow.
And I was like...
What year are we on now?
Yeah, we're like 20 in.
All right.
So this is why it's relevant. And I remember being like, I was a lot younger then. I was like, 40 years? God, I hope not. I hope we're like done in 10. He might have been right. So look, we've made significant progress, and then so if you go back at that point, and even when I started CMI, you had almost 2012, 2013, you had almost no payment in value-based care. I mean, so you were starting, and you were like, let's set up the ACO program in the first iteration. Let's set up CMMI. I was the second CMMI director, but let's make sure we launch these programs. And so you went from 0% of payments to about 30% of payments. Then you have the era with you and Adam and others where effectively, okay, how do you push to two-sided risk? How do you streamline these programs?
Take the next step.
How do you take the next step? Terrific, great maneuver. You fast forward to this administration and they're taking the next steps. And if you look globally, we're heading towards sort of 50% in some significant value-based care arrangement. Now it still varies a lot, more in Medicare, less in Medicaid and commercial, but I think we're trending in the right direction. I think the question you asked is the right question now. How do you make it go faster? And that's the question we at Optum are working on. So, I get asked this from an investor perspective on a total addressable market, and they say, well, 5 million people in fully accountable to their lives, fully accountable, management. What do you think the total addressable market is? I would argue the total addressable market is every American.
Yeah.
And so we got a long way to go.
Yeah.
And it's not just us, to be clear, but as a system, I think I would argue we need to think about across commercial Medicare and Medicaid, how do we get as close as possible someday, hopefully sooner rather than later, hopefully less than 40 years, in a relationship where there's an accountable entity for their total cost of care, quality, and experience. And when you do that, you go back to that patient story, they get better results than a dual eligible that better than anyone. The typical dual eligible has incredibly fragmented care because they're in Medicare and Medicaid with different payers and a fee-for-service system that is not coordinated.
So my thought on this is that part of the reason why we did not have the scale is that we had the vision, we had the policy, we said this is what you're going to pay you, but that we really did not give the tools on the front lines to be able to do value-based care. We didn't have interoperability. How do you expect the providers to manage care when they don't have a complete medical record? They don't know. It's like, okay, this patient's coming in, they're in this contract, that, it's too much on the front line when you're trying to manage demand and to be able to deliver value-based care in the way that we envisioned. And so, part of my journey to Oracle, and I think when we were building our ambulatory EHR, was to say, we want this to be a value-based care EHR so that if you want to do value-based care, it's right here. So if the patient comes in, you understand they're in this arrangement, here are the quality metrics, here's where you are on managing cost of care. So that's my view in terms of where maybe the tech and some of the rules around interoperability were not there. And that you had to solve those problems first before value-based care could scale. That's my thought. But you're talking a lot about technology generally, right? Call centers, but how are you thinking about AI now? So technology's always been the potential to use more tech, but now within the era of AI, how are you thinking about it from United, Optum, using AI?
Look, high-level principles, we have over 1,000 use cases, but now we're scaling some of them, and our key goal with Sandeep and the whole team is how do we scale those broadly? So that's sort of the phasing we're in. We're willing to partner, which I think is a little different than Optum and UnitedHealth Group historically. So we recognize that we're learning, we've got some talents, expertise, capabilities, and connection points, but how do we partner across the system to drive the change we want? And then I'd put it in zones we're working in, and I'll once again mix sort of stories and data. The clinical zone, we talked about this right before, short clinical story. My first week as an attending at Children's Hospital Philadelphia, this happens at Children's Hospitals. You get a child who's been referred around America for a couple years. No one's figured out the diagnosis, about a 500-page chart. Takes me till about page 283 until I'm like, oh my gosh, this kid has a metabolic disorder. We end up making the diagnosis, but in today's world, no human should have to read through 500 pages. You use AI, it does that, it tees up the possibilities, it makes the clinical system much faster. So we have work there to say, help our clinicians, and I know you do as well. What's the population? What's the next best action? What should you think about? That's clinical zone. Administrative zone, we touched on a lot. How do you make it faster? How do you make it simpler? How do you make prior authorization real time, simple, automated, et cetera? I'd put customer service and administrative functions. That's another zone. And then the last one we haven't talked a ton about is, on what I'll call sort of consumer journey. So to come back to like a dual eligible patient that's on Medicare and Medicaid, we can separate those patients based on the data and say, okay, this is a patient that looks like this, a 40-year-old who's disabled, who has these needs. How do we interact with them digitally and through clinicians to get them the care they need? Or this is a 90-year-old like I described, and really trying to understand and interact with people at a much more personal level. So we're using AI to do that as well.
Yeah, I think it's a great point, right? Because for the patient, right, duals is perfect, right? They could be on Medicaid, obviously on Medicaid, they're on Medicare, but they could have multiple providers and multiple payers, right, as well. And so if you think about it for the patient, they could be navigating 5 or 6 portals on their phone with all these different people trying to manage their care, right? So that's one of the problems that we're trying to solve is how do we bring it together, even in the context of the portal, right? To have a single portal where everybody can link, but for the patient, it's seamless. These are the medications you need to take. These are the appointments that you need to have. And that when there's even 2 payers involved, right, that they can also be coordinated as well.
Yeah, I think it's a great example.
Right, of how we want to do this. So, in terms of going forward, right, and sort of where we are today with AI, what are you seeing as obstacles, right? There's a lot going on in government, a lot of discussion, obviously a lot of pressure on MA, but as you kind of look at the landscape with the goals that you want to accomplish with AI and just generally, what are you seeing right now from technology, organizational? What are the barriers right now in terms of getting to your goals?
Yeah, I'll name a few, and then I'd love for you to name a few on this one too.
Okay.
The first barrier I think is almost like cultural/leadership, where we still have a tendency in healthcare sometimes to point at the other entity. Oh, it's that person's problem. It's that's entity, you know. And the payers get pointed out a lot too. Optum, which sort of healthcare services, nobody knows what we do. By the way, we serve like almost 130 million plus people, so we serve a lot of people across the system in some way. So sort of stop the finger pointing. How do we actually work together? How do we solve it together? How do we partner? So that's sort of the cultural barrier I hope we can overcome. Policy side, I actually hope they continue a lot of things you started and others started. You know, interoperability. How do you free up the data? How do you truly empower consumers, patients, people to manage their own health? How do you have regulations that set the goals, or in programs that set the goals and the outcomes, but don't micro-regulate how you get there? Because then you limit.
We never did that. We never
I hope we didn't,
micromanaged regulations.
But it's really hard. You know, it's hard because you sit in that regulatory seat and you're tempted sometimes to be like, oh, I think our team knows what's best. But you know, try to set the outcomes, not the exact detail. And then, look, you and Oracle probably know more about this than I do. I think AI is going to be like the internet. Like, I literally think there's going to be, 5 years from now, we will do things we can't have imagined right now. And so then I think the key to that and what we're trying to do is like deploy teams at the front line, like with clinicians, with call center reps, and just learn rapidly and test and learn quickly, and then what works, scale it. I think those are some of the things we're working on, but what do you think?
Well, I mean, one of the things that's priority for me, right, is if you look at, you talked about drug pricing and the cost of healthcare, and to some degree, there's a lot that we can do. There's a lot of inefficiencies in the system, and that's where we want to focus. Because at the end of the day, right, I don't think that you, as a pediatrician, as a doctor, you don't want to be in the position of saying, we don't want to provide this care to a patient, right? Nobody wants to be in that position. And even when I was running Medicaid and Medicare, it's like, that's not, people have paid into these programs their whole life. There's an expectation around these programs, whether it's government or commercial, an expectation, a social contract, if you will, around healthcare. So no one wants to be doing that. And there are these big old innovative drugs that are coming out. No one wants to say no to that, and we shouldn't. That's a good thing. So to me, I was less interested in that. But I looked at the 25%, 25, 30%, whoever's doing the study on administrative costs. To me, that's ridiculous. That's wasted money.
I agree.
And that if we can retool that, we have a better shot. And I think to some degree, we're seeing the problems are in some ways worse. When you and I were in office, I don't recall having a conversation about getting an appointment. That was not something that we were talking about. It was not on our radar, right? We were not talking about workforce. And that's just not that long ago. And now the conversation has shifted. We have this aging population, which is a good thing. People are living longer. We don't have the workforce. We're struggling, and people are having trouble getting just basic appointments for primary care. And if we don't do that, right, that's going to result in higher acuity care. So when we look at coding intensity and things like that, the underlying problem would be maybe they just haven't been managed earlier. So, tremendous opportunity with AI to help in those things, right? Like, what if we just showed our patient portal yesterday with OpenAI, kind of a version of ChatGPT, meet your longitudinal health record. But really the idea is that also maybe in a future world is able to address some low acuity care, some of the questions.
Totally.
So it's that kind of thing. When I look at AI and the potential, it's getting out. It's at 25 to 30%. Let's address that. There's a lot of back and forth, payers and providers, and some of the friction. You and I have been on both sides of it, so we kind of understand it. I understand that payers they want to ensure that evidence-based care is being followed, and that if there are lower cost alternatives, that those are being explored, because that impacts the premium, right? At the same time, providers are trying to do their best for their patients, and they're frustrated with the bureaucracy and just the time that it takes. And so to me, that's where the opportunity is, right? We can do this. We can automate this stuff. It does not have to be done manually. We don't need the fax machine anymore. And we can embed those prior authorization rules right inside the EHR. So, the doctor wants to do something, it's like, yes, no. And so some of the AI that we're bringing in isn't just clinical, because that's one piece of it, but providers need to be doing that decision-making in context of what the payer
Yeah.
Is it a covered benefit? Does it require these rules? And so, that to me is the opportunity, is to really focus on the administrative costs.
Yeah, look, I think great comments. I agree wholeheartedly. You also hit on two components in there. I'll just amplify. I think in primary care, and I'll add mental health. I think we have an opportunity to use technology to really broaden out the care team. No primary care clinician can do everything we're asking them to do today. Like, it's not humanly possible. So how do we enable them with technology supports care teams to get done what they want to get done? I think similar, and you mental and behavioral, I think we have an opportunity, a lot of need, not enough clinicians, and certainly not enough psychiatrists. So how do we maximally use that workforce so we get the right people to the right level of care, then get them maybe to a lower level of care, but make sure we stabilize them. So I think there's a huge opportunity for technology in both of those spaces as well.
So, one of the things, right, so when we were in government, we had an opportunity, and I think we tried some things around primary care. I know you in particular had some models around bolstering primary care.
Yeah.
But at the end of the day, right, primary care, I think for those providers on the front lines, right, whether it's reimbursement, that's been the biggest challenge.
Yeah.
What are we doing for primary care and mental health? Because I'm kind of, my thought is that because the system as a whole, whether government, commercial, whatever, hasn't done enough, it is now not even is it not getting better, it's actually becoming harder and harder. And not addressing that is giving us the downstream costs that we're starting to see. So when people are coming in, they're sicker, they haven't really been attended to. But why have we not, as a country, as a healthcare system, you and I were in government. I think I gave some raises to the primary care doctors. And
we did.
I can tell you the surgeons were very angry at me, but I did. But it hasn't, it hasn't worked.
No, it's, I try not to have regrets, but sometimes, I feel like we push really hard, but you never get everything done you want. Look, on the positive side, and then I agree, we haven't gotten to where we need to. We did push money towards primary care. We put in collaborative care for mental health. So a number of changes, measures, PHQ-9, et cetera. So did move the ball forward, I think, in mental health and primary care. The differential is so large in the US, I just don't think we fully closed it. I will say in our value-based care models, we highly incentivize our primary care clinicians. And our burnout, I should have said this earlier, our clinician burnout rate's about 36% lower than average, including for primary care. I think a lot of that is we have the technology, the system support around them. The financial model is actually value-based. So you have a lot of systems that are like, I do value-based care, but then they pay their docs or clinicians, RVU, fee-for-service productivity. That doesn't really work. We totally flip that around and incentivize and pay our clinicians in a value-based way. I think that matters substantially as well, and with the U.S. system, I think that moves well. That also does, by the way, reduce the discrepancy between primary care and specialists.
So reimbursing them in a value-based context. So it starts with that.
So our incentives are not, if you're a primary care value-based clinician, the way you think about your compensation and your incentives is around a value-based care model, as opposed to and so therefore they are incentivized to think about the whole population, and we provide them, you said this well, the tools, support, the ability to be successful. So I think, but that needs to scale nationally. The reality is the vast majority of primary care clinicians in America are still struggling in a fee-for-service system tied to 15-minute office visits. And that doesn't really work well for the primary care clinician or the patient. So, and I think that's why you see, honestly, some concierge medicine and other things popping up, because the system is under pressure. Last thing I'll say, in North Carolina, when I ran a Blues plan, we made a commitment to try to invest at least 10+% of the total medical expense dollars into primary care. That did mean investing in primary care, population-based payments, value-based care, higher baseline rates. The theory at the time, which we believed in, was if you invest in primary care, and we saw this play out, you're actually going to get better overall system outcomes.
So you've done value-based care contracts with your, not contracts, but just payment with your own providers. As you try to roll that out, these contracts, scale outside of your own network, What's the response been? What's the challenge been on that end in
Yeah.
terms of, because you know you're doing it inside yourselves, you know how to,
Yeah.
you know that it can work.
It's a great question. Actually, sometimes, let me give you the data because sometimes it gets quoted differently. We actually only have about 10,000, little more, employed physicians. We have a large number, 80,000 plus, that are contracted in tight relationships, which means they're choosing to work with us. And that's growing rapidly. I was just I've traveled a lot this week, and Monday I was in Salt Lake City with a bunch of them. And I think it's growing because the current system doesn't work for them. So these are, often some very small practices, some are IPAs that are bigger groups, but they're saying, look, the current model doesn't work, so I want to join you. I want value-based care contracts, I want the tools and technology, so I want to be part of Optum. And they may join us exclusively, they may join us in other contracting mechanisms. We're trying to give them flexibility to join a value-based care system, and it's actually working extremely well, and I think it is because those physicians, those clinicians, to bring it back to medical, you go to medical school because you want to care for people. And we make the system pretty hard sometimes for physicians and clinicians to do that. So if you flip it, whether you're Oracle or Optum or whoever in the audience, and you enable that physician clinician to do what they want to do, which is just provide amazing care to patients, both the person in front of them and the population broadly, that excites them. So I think that's the work we need to do.
Now, that's a great point. So beyond contracting, better tools and technology, which I do think is really big right now for providers, what else are you doing to maintain that workforce of providers? Because that's a big one, right?
Yeah, look, we do a lot of work on experience, burnout. We're using, which I'm sure, various ambient technologies to help document for them and testing different things. How do we use AI to help with documentation? You said this incredibly well. How do you take down the administrative cost, both for the clinician and for the system? And there's a huge opportunity, as you alluded to do that. So that's where a lot of the work lies. Look, I think we're still pretty early innings, of this journey, if you will. I think we're sort of scratching the surface, whatever analogy you want to use. And then, even in my clinical practice, I still spend more time than I would like in the documentation. I won't name the HR in my hospital, but I think I've told you who it is.
It's not the right one.
And I don't have any, I just work there.
One.
I'm just a small town pediatrician, shows up and sees some patients. But I still use smart phrases and posting, but it's the same things. Actually, I've never told you this. This will totally make you laugh. This will be a good, so when I was a resident, my handwriting is horrible. And I believe in efficiency. So this is before EHRs, I made all these Word document templates that was the 20, 40, they kept growing, most common thing in pediatrics, and that meant I could document really fast because I would just insert the core details and I'd be done instead of rewriting it every time. And people were like, how's Conway so fast?
You're a good
and I'm like, I use a computer. There's these things called computers, people. We could use them. And so, you go to an EHR, and I'm going to be careful here, I'm still using smart phrases, which is basically fancy Word, copy and paste and edit. So look, there's an era, which I know you're working on, others are working on, we're working on, let's move this, we're in a next generation of technology, right? It should be able to, I do a visit and it documents a personal interaction I had with that patient, exactly right. It helps me code appropriately for the conditions that patient has. It helps me understand and make sure I ordered whatever is necessary. If there is a lab value that's out of order, I don't have to hunt and peck and find it. It is queued up to me.
I'm smiling because I think he's giving the Oracle EHR commercial, right?
But
this is the commercial.
That's what the flow should look like, right?
Yeah.
And I think we still have work to, implement that flow, and I know there's a lot of people working on it.
As following this, Patrick's going to get his demo of the new Oracle EHR. So how many of you out in the audience have now seen the demos in the audience? You can kind of see some art. Yeah.
quite a few.
So everything that you just described, that's
Show it to me.
actually, it's
All right.
there. It's actually right there,
Good.
right? It starts with the summarization. You talked about having to navigate 200 pages.
Yeah.
This gives you the summary. It'll give you next best action. So we think we've kind of cracked the code on it. And I think it's important because the amount of burden the providers have, I think as people didn't train, I mean, there's scientists, they're studying biology and chemistry and anatomy, and then to spend your time typing and cutting and pasting. And I think that it's, I heard this term, moral injury, right? That they felt like they were being taken advantage of by the system. And I think that that's true.
Yeah.
And so, part of our focus has been on that and addressing that piece. So I'm excited for you to see this afternoon, and then hopefully next year we'll be having a totally different conversation.
Me too.
You'll be talking about moving from the dark side to the light side.
Yeah, no, that's awesome. Look, I'll embarrass you for a second. I worked with Seema in different contexts over time and learned a lot from you. And we have people from all over the health system in the audience, I'm sure. Look, I think the core thing the UnitedHealth Group mission is to help people live healthier lives and make the health system better for everyone. Many of our organizations have missions, they may not be that wording, but are about making the health system better for everyone. I think our collective challenge, which to your pace question, which I sort of answered, we got to go faster. Because every day, there are people falling through the cracks, not getting the care they need. There are clinicians, physicians not getting the support they need. So how do we construct and partner and work on that system together? Because the affordability crisis is real for public and private payers and employers. The quality and experience is uneven. I work at a safety net hospital that I see the failures of the system. And so how do we, collectively work together to improve that system faster?
Are you excited at this juncture? I mean, so as you
I'm always
describe how
excited.
you're feeling, you're a happy guy, as I remember. But at this juncture, right?
Yeah.
You've been, and are you looking at the future with optimism, fear, concern? Like, what's the emotion?
Look, I didn't see that. Optimism. Like, honestly, look, we got a lot of work to do, including at Optum and UnitedHealth Group, but, the scale of the opportunity is incredibly exciting, and I can see pockets of significant positive impact, as I described. I pull one other reel. I was in our Atrius clinics, we're in the Massachusetts area, and you just see care teams just like, I'm testing this, I'm learning this, I did this, I'm taking care of this population this way, and now we're sending people in the home, and we're doing these things. I mean, it's amazing. I'm optimistic about the future. I also, of course, have concern about the near term. Like, we're in a period on the sort of cost quality trajectory that I think is not going in the right direction. So that causes concern. And how do we, turn that around?
Yeah, no, I feel that sense of optimism. I do feel like today there are different tools now that we didn't have, right? You talk about the issue of uneven care. But with technology, right, you can put that in there so that every provider knows what the latest treatment is. We have an opportunity to address the administrative costs. We have an opportunity to address friction. Yeah. We have an opportunity to do things accurately so that we all agree that this is the right path forward. So yeah, I'm excited. So our next panel is going to be Stacey Amin and Lawrence Talon from the MHRA, so regulators now from the UK. So we're going to be talking more about the regulatory side, and any before Lawrence comes on board, any parting comments for regulators, and even this is more device and and drug regulation. Any thoughts parting?
Yeah, I promise I'll end ahead of time. Look, thank you for having me. For all of you in the audience, thank you for being here, and thank you for the work you do, and let's improve faster together. And then on the regulatory frame, I think I go back to what I said, focus on the problem you're trying to solve and the outcome, and then how do you set up the policy and regulatory framework to achieve that outcome. So thanks for having me.
Well, thank you for coming, and I will tell you that I feel I'm just I'm glad that United has you at the helm, and I know you have a heart for patients and for doing the right thing. So I couldn't be more happy for you, and thank you for coming today. It was good to see you.
Thanks a lot.